Good afternoon, everybody. It's lovely to be with you. Some of you have heard me before, seen me either at the task force or out doing visits. And those of you that have an early implementer site in your midst will probably see more of myself and the task force in due course. And for that reason, I think it's important that you hear about who we are and what we're doing. So, without any further ado, you are as aware as I am of the contextual background to the call to action. This was all due to new coalition policy, which was agreed in February 2011, about increasing the number of health visitors. The model of care, though, however, has been evolving over a period of time in response to new evidence from people like Frank Fields and Claire Ticknell and Elaine Munro and others. And importantly for me, because that's where I come from, which is actually about the children and their families, it's also in response to what families want. Quick responses, knowing who their health visitor is, working together and getting better support. The call to action model of care is all about getting improvements in care by having prevention rather than reaction, and early help and early intervention. So what is the task force? Well, it's actually an independent committee set up as part of the governance as opposed to governance arrangements of the call to action. And our primary purpose is undoubtedly to be part of helping all of you to improve the outcomes for children and their families. In particular, the task force is there to help to provide some challenge to the delivery of a call to action, to champion the vision, partly by going out and meeting with you in your workplaces, but also by speaking at conferences such as this, although I don't think I've ever had to talk about what the task force has done before. We're there to help to challenge some of the delivery of the programme and ensure that there's a promotion of the contributions of everybody that's involved in it. Importantly, I think increasingly it will become important to be part of the supporting of the learning that's come out of the first early implementer sites and now the second implementer sites. So that whole notion of championing and challenge and promotion and supporting are the key elements of what we're about. It's also important that we have recognised right from the beginning and taken into account the wider context of public health and healthcare and where health visiting sits within the health and social care and education framework. And more recently, very much around local government, and I'll be coming back to that in particular when we talk about membership, but looking at the importance of the health and wellbeing boards. So how have we been doing this? Well, we've tried to become increasingly outward focused. So some of you, one or two of you I've already met today, have had a visit from me in the last couple of weeks. Each of us are taking parts of the country and going out and doing visits to sites. And some of you, who I've also met here today again, have been in and presented to the task force. And the reason for that is not that I don't believe my civil servant colleagues or other people who are working for this programme, but actually we're independent, and it's really important that we hear from the ground floor exactly what is going on, what's working well, what works less well, why there may be barriers, and what we can help to do to look at how things are freed up for you. We have been very much looking at the strategic elements of call to action rather than getting involved in the minutiae. And it is absolutely clear, and was clear right from the start, that we weren't about redesigning what was already a template. There were things that were a given, and those were challenges that we couldn't actually make. And finally, to provide advice and challenge to the programme board, which is the internal board inside the Department of Health, of which I am an observer, although those of you who know me well know that I may observe, but I also speak. I think, to be fair, it has taken us time to settle as a committee. It took us time to actually find a way of working which incorporated the terms of reference that we agreed, but also to try and be helpful to those people that have the primary responsibility to deliver what is a very big delivery programme. And part of that was because of the fact that there were so many givens. If you're given a blank piece of paper, you can challenge each other and be very creative and in the way that you work. Well, we weren't able to do that because, for example, the total number of health visitors was set before we came into being. But what we have got is a membership of people drawn from a wide range of organisations and areas of regulation and different professions. And most recently, we have brought in a local authority director of children's services to reflect what I was saying about the importance of the health and wellbeing boards now. And this is my moment just to pause to put on record the really great support that we've had from Lord Victor, who's been an entertaining and challenging in his own right member of the committee. It's been great to have him, and we look forward very much to having a replacement from the CPHVA to join us shortly. The important thing is that the members that are on the committee attend in a personal professional capacity. They're not there representing their organisation. So this isn't an opportunity for substantial union lobbying. It is an opportunity to try and establish some real professional debate and challenge into the system. So what has the task force found? And these are fairly generic things, and I can go into more detail in the question time if you wish. But we have found very sound bases for new development in the places that we've been into. And in a way you would expect that, particularly with the first implementer sites. It's inevitable that the sites that were chosen would be sites that actually were stable enough to take on new development. I think it's been reassuring to see that there's a far greater emphasis now on the Healthy Child programme. And I do believe that whilst there are clearly issues that are still there in the profession with regard to morale, there is a new confidence that I think that has sprung up amongst health visitors, not just to deliver this programme, but a confidence that has arisen because of the raised status and profile of health visiting. There have been all sorts of what I call ripple effects, things that perhaps one wouldn't expect immediately to happen as a consequence of being an early implementer site. Things like improved relationships at the moment between strategic health authorities, PCTs and provider organisations, but also with the new organisations as they're beginning to grow. The greater use of data. When I go out and do visits, people talk about the data they're collecting and how they're using it. Admittedly, at the moment, a lot of it is hard copy data, but it is being used, and I think that's important. Very key to all of this is the quality of the leaders who are implementing the new approaches. And I have to say I've met some really inspirational clinical leaders and managers of these programmes. And again, I think there's often been a history of good leadership in these sites beforehand. So overall, I believe that health visiting is absolutely changing and responding to the challenge that has been presented. It is a huge opportunity as well as a challenge. And of course there are challenges, and we are really aware of the scale and pace of the expansion of the health visiting service, which is against the backdrop of the decreasing number of health visitors that has been a historical position, particularly with the number of health visitors retiring because of being an ageing workforce. The challenge of working within a financial context which is hugely demanding at the moment. And I couple that with having to try and retain staff in existing posts. So the other challenge is about retention and also encouraging people to return to practice. I met an individual just this week who had returned to practice who didn't look old enough to have been out for 19 years and has come back with hugely renewed vigour and enthusiasm. There are the challenges around raising the morale and the skills of the current workforce, and the implementation of a new vision whilst actually having to cope and manage with the current changes amongst the NHS and the pressures that those create. There are also other challenges. The fact that the third part of the register is left hanging in the air still. The duplication of returns that sites have to keep sending in, although I do think that that has diminished and the demand has been somewhat less recently. We've got really significant issues around getting the communication out to people that really matter and need to understand what a call to action is all about. And I list some of these here. GPs in particular, there's a big push at the moment to try and inform GPs about the new health visiting role. The local authorities I've talked about. Maternity services, I know some of you are doing projects around antenatal care and the difficulty of actually working in a very collaborative way with midwifery colleagues. And for me, one of the things that's been an issue right from the very beginning is about actually getting executive boards to understand your contribution to the improved outcomes of public health in the populations that your organisations serve. The significant problem we have is that the average length of stay of a chief executive is 22 months. And the average timescale that you people are working to improve the healthcare of populations is about 20 years. And so, you know, when you've got teams of people at the top of trusts that actually have to achieve short-term wins and are having to manage against significant targets, it's very difficult for them to take on board that what you're doing have also got significant wins for the future. So that's why, for example, we have the NHS Confederation as a member of the board, of the committee. Supporting staff through change, I've said that that's a huge challenge. Maintaining skill mix, I know, is a big issue for many of you. Maintaining the skill mix, particularly with nursery nurses, but not solely and only. And then having to actually do all of this with IT systems that don't necessarily work terribly well, don't connect well, and don't manage to collect the information that you're wanting in the way that you want it, and it's not always available. So we're very conscious of that. So the huge challenge for all of you is the massive change that's going on across the NHS against the changes that's happening within your profession. But I've been out to one trust only this week that talked about actually how the whole trust is responding to a call for action. And I think that's brilliant, and the way that they're all working together. So what do we see as our task now? Well, certainly to try and sustain the momentum amongst the first wave, but ensure that that learning from the first wave is embedded to help to inform the second and subsequent rollout, which is actually about ensuring that the whole thing is sustained. And for me, to make sure that actually the rest of the agenda and that the rest of the workforce is not forgotten in all of this. You're one part of making things better and improving the care for populations. And it's not just about health visiting, although I realise that that's your primary interest here. And so, finally, it's about actually remaining focused on the children and their families, which is what we're trying to do with this programme, which is actually to improve the quality of their service provision. So thank you very much for listening, and I'm happy to answer questions.